everyone. I think we'll get started. I'm very pleased to be able to introduce Matt Mustaine. He has spoken at this Grand Round before, but I think a few years ago, so it's great to have him back. Matt has been a PA for 15 years now, the first 10 years of which were in the USA before moving to the Isle of Man about 5 years ago. He's currently working for the University of Central Lancashire, where he's teaching clinical skills to the first cohort of PAs who are at West Cumbria Hospital, I think, yeah. And I think now there is some interest in PAs within this organisation, and we are currently have some PA students coming through on rotations and stuff. So I think it will be really interesting to hear of his experiences from Cumbria. And I'm interested because I grew up in Cumbria, and I think that in terms of kind of rural, isolated places, there's probably a lot of similarities to the Isle of Man.
Thank you. I'd like to thank Allison for the nice introduction. Thanks to the Education Department for inviting me out to speak. The background picture for my slideshow, or for my presentation, is actually a picture of Douglas Bay that was taken on Boxing Day this year, so just not too far from my house. And we like the island a lot. It's a nice little idyllic island, great for family and great place to raise kids. What I'd like to do today is talk about how physician associates kind of give you an idea of how they're trained and what their capabilities will be once they've qualified. So we're going to start on one end of the bay where your knowledge base is maybe a little bit lacking, and work our way up to the shoreline, so hopefully we can get some idea of get on dry land as far as what our understanding is. So we'll talk about how physician associates are trained. We'll talk about what level of knowledge the PA students will have when they get here and how you can optimally interact with them and hopefully teach them and hopefully utilize them to some degree. And what experienced PAs are capable of once they're qualified, and how the role is different from other members of the multiple disciplinary team. I'm going to have to refer to my notes occasionally just so I stay on track, so bear with me. So just recently they did start a consultation, the NHS and Health Education England, about problems there are with the workforce currently in the NHS. And they developed a paper, put out a paper that will be completed, a consultation in March of this year. And it addresses several issues about problems with the workforce. And it tells us things initially in the first few pages that we already know. One of those things being that the population of the earth is increasing logarithmically. When I was 15, the estimated population was 4.5 billion, and now it is 7.6 billion. So almost doubled within the past almost 4 decades. So we can expect that it's going to double again in at least another 4 decades, if not more. And this graph is pretty much on track as far as what the population is going to be by 2075. Probably more, actually. And we're all growing older. That is, I'm also experiencing this firsthand. And people that are growing older have more medical conditions they have to treat. And this one's for our nurses out there. But one of the things that finally drives home is the fact that there is a problem with staffing shortages. And we have a shrinking workforce. And they have a couple of graphs in there to talk about the shrinking and shortage staffs in on the top graph in just general health care. Nursing being hit particularly hard, 8.6 in general on average, but mental health also being hit very hard. We all know that, and that's happening in the States as well, as far as mental health goes. And in the bottom graph, it shows vacancies in medical positions of 9.6% vacancy rates across the UK, especially in emergency medicine and acute care medicine. So one of the things we have to worry about is how we're going to, we hear the term recruit and retain staff. And Cumbria is a remote area as well, just as the Isle of Man is. So it's come up with ways to address this situation. And I like to use the word acquire rather than retain, because they're having difficulty recruiting people coming to come to the Cumbria to actually practice. So what they're doing is they're using staff that they actually have there already and trying to actually train them to the point where they can work with the multidisciplinary team to actually help the doctors do their job, and the nurses as well. The two trusts that are up there, the Primary Care Trust, the Cumbria Partnership Foundation Trust, one of the things they've done is they've actually merged the two trusts together that manage primary and secondary health care. so they can get a better interaction between those two departments and get better communication between those two, primary and secondary healthcare. And they've gotten together. That's one of the things they did to help manage their problems up in Cumbria as far as how they're going to deliver healthcare to their population. The other thing they did is they got together with the University of Central Lancashire, and this is where I work at West Cumberland Medical Education Center. And they developed an idea of how they were going to train people to fill some of these roles that are vacant. And they came up with a two-pronged approach. And they call it a composite workforce program. And the first part of that program is they took nurses that were already trained and practicing in Cumbria, that had been practicing for 10, 20 years, some of them, and made them advanced clinical practitioners, put them in a program where they were going to teach them how to do medical assessment, clinically treat patients, and help run secondary care and get patients to the hospital. 11 of these ACPs will soon be certified. They're all trained through North Cumbria University Hospital Trust. But they've also got another advanced program that was started and is actually run by UCLan, where they're taking 5 of these ACPs and they're going to train them even further for another 2 years to the point where they're going to be working alongside medical registrars in the composite workforce to manage these patients that come in through secondary care. Gershon Davis is the consultant cardiologist who's in charge of this program, and he's got two GPs working with him on the right there, Ewan Fletcher and Catherine Bly, and they teach these 5 clinical practitioners that are going to be certified in the next 2 years. And again, they will be joining middle grade senior decision maker composite rota and be working alongside medical registrars to help manage patients coming into secondary care. So that's one aspect of how they're going to train people that are already there to work up to levels where they can utilize them effectively in a medical multidisciplinary team. The other aspect they're going to do is they've got together with UCLan and started a pilot program to train physician associates. And currently it's a postgraduate diploma. We've got the authorization to go ahead and create a master's program as well. But this is the first cohort up in Cumbria, currently 14 students. And that's myself and Dr. Eric Bader, who's a GP in the area for at least last 20 years or so, who's the program lead up in Cumbria. And that's us in front of West Cumberland Hospital, A&E, with our 14 students. But one of the persons you don't see there is Dawn Sawyer, who's a physician associate that was hired along with me. But she wasn't there when we took this photograph because she was still dealing with visa issues from the U.S. So she was happy to come and work in a remote area to try to train some of these people, because she comes from an even more remote area. For the past 10 years, she's been working in Alaska. And in these areas, they don't have healthcare in these small villages. So what the state of Alaska did is took practitioners and doctors and sent them into the small villages to actually train the people that were there to do their own healthcare, deliver their own babies, manage their own disease processes, because the nearest hospital could be hundreds to thousands of miles away. They pretty much have to fly patients when they get in critical situations by plane. There's no other way to get where you need to go. So it's a remote area up there, and she was happy to come down to Cumbria. And this is a little photograph of Derwent Water, which is in Keswick, right outside of where we work and teach. And it reminds me a lot of where I grew up when I was a child. And I would spend days and days on bikes in the summertime, myself and my friends are going out. And I remember many a time when I'd have to hobble my bike back home several miles when it was broken. I had to fix it. And I had to have multiple tools to try to do different things, an Allen wrench or a spanner or a crescent wrench. And I thought to myself, wouldn't it be nice to have a tool that was general purpose that I could pull out of my pocket and just use right there when I needed it to. And I'm going to have to come over and fiddle with the video here for a second.
Sonic screwdriver.
It's only a door handle.
So that's my analogy, is that physician associates are kind of like a sonic screwdriver. They're generally modifiable and you can use them in multiple clinical situations whenever you need them. When I first came and did a presentation about 2 years ago, I think it was 2 years ago, this is one of the slides from my initial presentation. And it took data from the 2014 UK APA census that was done at the time and got some hard numbers about how many working PAs there were in the UK, and there were 220 according to that census. It had a 68% response rate, which is fair. And they worked in acute medicine and A&E in general practice, but they also had some subspecialties they worked in as well. And at the time, there were 6 working on 7 programs at that point. They also estimated the number of students, and this is kind of the part that's really most remarkable, is that they estimated about 107 students based on how many students were registered in those 6 or 7 programs, and they got an 68% response rate. 73 students responded, so there were 73 really known students in training at that time. And when they recently did another census in 2016, they had a 58% response rate. They had 150 practicing PAs, so that number's a little off just because it's lower than the other one, but the number of students has accelerated quite a bit, from 72 to 373. When they look at how many students are actually registered, it's more consistent with about almost 600 students currently in training throughout programs. 60 of these people that are actually practicing work in GP and A&E, and a lot of them are educators, of course, because there's so many PAs are training. And 19 of those educators also practice in clinical environments. And that's also what I do. Me and Dawn are actually contracted through UCLan to teach at the university 50% of the time. And then we have an honorary contract at the hospital, at West Cumberland Hospital. We work in the EAU, Emergency Assessment Unit, for another half of the time. We probably both end up putting in probably more like 40 to 50 hours a week just trying to get this program started, because we spend much more time in the university at this point. 23 of those 150 PAs practice in acute medicine, and quite a few of them are going into geriatrics now. And they're spread throughout various different subspecialties. But now there are over 30 UK PA programs that actually have been developed. And what we're going to talk about now is a little bit about how these programs are designed. So we're going to look at this particular program is from St. George's, and it's based on a lot of the programs in the States, how those were developed. And initially, those programs, this St. George is still set up this way. The first year is completely academic with lectures on a daily basis. They do mix some rotations there. You see in general practice, they have some placements there throughout the course, but in general, they spend most of their time in clinical lecture and didactic lecture throughout the day. And then the second year is all made of placements that they rotate through. The students you're getting that have come through ONG, I believe, and the ones you're going to have through surgery actually come from Liverpool, and we actually pull the same students when we do interviews for these placements in the Northwest. We actually pull students that apply for Manchester, Liverpool, and University of Central Lancashire, and pull those students together and then distribute them between those 3 programs. So your Liverpool students will go through a similar type of program that we do have at University of Central Lancashire, which I'm going to describe now. We've set it up a little different in that we've taken the didactic part and the clinical part and merged the 2 together. So they're actually doing placements while they're doing didactic work back and forth at the university. And it's nice because they're actually in West Cumberland Hospital and GP practices, so they can go back and forth pretty easily too. They're in close proximity to each other. The first 16 weeks is all academic. It's all lecture material. It's all didactic. So we go through anatomy, and it's very clinically applied anatomy. We go through physiology, some complex concepts such as gas exchange and acid-base balance, respiratory acid-base balance, and how that's linked to the renal system, renal secretion, renal excretion, pathophysiology, hematology, immunology, microbiology, and then how to interpret data analysis, how to look at diagnostic tests, especially linking it back to their anatomy lectures, how to interpret X-rays and CT scans. And they also have a really good basic knowledge of ECGs. They understand their limb leads, they understand their augmented leads and their chest leads, and they know how all that works, and they know the waveforms. So they have a good. Your students are going to have a good. They're going to have a good basic knowledge of this. I had one of my students came to me that they actually had a lecture when they were in the hospital, where they were offered to come to a lecture that some of the doctors gave about ECGs, and one of the students was kind of disappointed because a lot of the material that they went through was the same stuff that we had done in the university. So what the students need when they get here and when they get on clinical placement is much more about practical application of this knowledge, how they're going to use it to determine what's going on. If you feel that, and also how to interpret other tests, how to look at an ABG and determine whether it's type 1 or type 2 respiratory failure, and how to treat that. As we all know that it's different doing didactic work and sitting and learning from a book as it is going to a clinic and actually utilizing and practically using that information. And they also go through pharmacology as well, because eventually, currently right now they're not a regulated profession, but they will be eventually. They just completed a consultation just this last month where the GMC has agreed that they would be the body to actually regulate PAs, but they would do so with some other professional bodies like acute critical care, special advanced practitioners, and anesthetist physician assistants, and they would regulate all those together as a whole body. But we're probably looking at several years from now when they actually get that done. So they go on this 16-week period where they're just being bombarded with all kinds of academic information, and they're also going through laboratory skills where we're teaching them how to do physical examination skills. We're also putting them into problem-based learning groups where they get into a learning group and actually learn, given a clinical case, and they actually look at how all the pharmacology and how all the physiology and anatomy relate to this clinical case they've been given. And they're also got a good access to a lot of anatomical models, which are all brand new. And we also have a new high definition dissecting table called Anatomage, which is a lot of fun to use. It's a full size digital dissection machine. And they also learn clinical skills. IV cannulation, phlebotomy, ABG taking, ECG, ordering, interpreting, and performing. And after that 16 weeks of doing all that clinical work, they're sent on rotations on placements. And 8-week blocks of placements throughout Cumbria. In GP practice, we have 7 GP practices that take on physician associate students. And we have West Cumberland Hospital. And in their first 8-week block, they do acute care, accident emergency, inpatient, and general practice. And then they rotate through those through 2 more placements after that, so a total of 3 placements. And during that time period, they're also getting together with their clinical advisors on the wards and going over clinical cases as well. They come back to the university for 6 more weeks of didactic instruction, and they learn, in our program, they go through obstetrics and gynecology and pediatrics, and then they go out for 6 more weeks of placements on those 2 particular subjects. That's where your ONG PAs were probably when they came in. So they had all this basic core knowledge, and they came in with some knowledge of ONG, and then they go back out for 6 weeks of didactic instruction and come back and go to placements in surgery and mental health. 6 more weeks of placements in that. And at the end of all that, they take summative exams at the university, and they also take national exams, which, as a matter of fact, they're taking today, January 12th. They're going to London and taking a single best answer exam. I think it's 250 questions, somewhere around there. And they're also taking observed structured clinical examinations on the 24th and 25th of this month that I'm going to mark for in the next 2 weeks. So they have to pass both of those in order to be qualified and get on the managed voluntary register and become qualified physician associates. The big issue is, how do you organize all the information? How do you know how deep to go into that information in order to have these people go on placements and have a good general idea of knowledge, being trained as general medicine people? And one of the things we do is we use a document that was created in 2006 by the Department of Health that is called Matrix of Core Clinical Conditions for Physician Associates. And they basically gave a matrix with two axes, one based on diagnostic process and one based on responsibility of management. So all the things that are considered 1A conditions are ones that physician assistants will be able to identify, put on differential diagnosis, diagnose and treat independently without having to go on with a regular routine referral or going back to their supervising physician. Class 1B are those conditions that they're aware of. It can still go on a differential list, but if they have to rule it in, they have to refer it or send it to a specialist in order to test for it. Does that make sense? And we'll go through some examples of that. Once in the 2A conditions, they are less involved with the diagnostic process, but once that diagnosis has been made, they can actually manage and treat it. When I worked in Phoenix, Arizona, I worked in rheumatology. And for example, something like polymyalgia rheumatica might be a 2A, because once the treatment plan has been developed and you know what's going on, the PA can take over and start doing the tapering, making sure the patient stays stable, and continue laboratory analysis. 2Bs are the ones that are much more uncommon, things that they're going to have to get knowledge of when they go out in their clinical placements. They'll be aware of them. If they reach a certain level where they've got a lot of experience, they could actually manage these kind of processes. Something like lupus would be considered a 2B condition. So all of our 16 weeks initially is built on making them understand these 1A conditions. When they first go into didactic learning, it's based all on these 1A conditions. So they go through respiratory, they go through cardiac, they go through GI, central nervous system, and renal as well. A little bit of endocrinology as well. This is an example of how this kind of matrix is put together when you're looking at systemic. Looking at it from a system standpoint, the cardiovascular system, all your 1A conditions are listed in the top left-hand corner. Essential hypertension would be a 1A condition. Secondary hypertension would be a 1B condition. So if they knew it existed, they could put on the differential diagnosis. But if they didn't know if there was an etiology for that hypertension, they would have to send it to their supervising physician or to a cardiologist or a specialist to help determine what the source of that hypertension was. And this is an example of how you would put this matrix together in a situation where you had a symptom and we're making a diagnosis. So they would be able to make a differential diagnosis with all these listed, and eventually could rule these things out in favor of the 1A conditions. And if it turned out to be a 1A condition, they could completely treat it independently and they wouldn't have to go back to their supervising physician or to a consultant to get any kind of input on how to treat it. Does that all make sense? Yeah? So on the census they did in 2016, the procedures and the tasks that were done by UKPAs primarily were medical history taking, physical examinations, and treatment and management education. So a lot of it had to do with rapport with the patient, communicating with the patient, communicating with the team effectively, and all the PAs did that. Quite a few of them did simple clinical applications like phlebotomy and ABG and IV cannulation, and a fair number did performing ECGs, urinary catheterization, psychiatric assessment, and there are quite a few actually working in mental health currently, and some more that want to go into it. Suturing and NG2 placement, a little less common, but there are some that do that, all the way to some more complex types of clinical things that a few do. I have a colleague in Lancaster Infirmary that's been a PA in emergency departments for about 25 years now. He's from the U.S. and he's been practicing here now for about 5-6 years, and he does all these procedures without the assisted cardiac catheterization. So, underlying all this is the ability to make some sort of rapport with the patient, establish some kind of communication when you're doing physical examinations, when you're doing medical history taking, and when you're doing treatment and management with patients. That patient being the center of the decision-making process, and the PA working with that patient to come up with a plan for treatment. And underlying all this is communication. So I like to make sure that the students are really well diverse in how they speak, how they take a medical history, how they write their notes and document things. They also have 4 different written assignments to do over the course of those 2 years. They're based on reflection, and they're based on evidence-based medicine, and they're based on research into medicine. So eventually we have somebody that's got effective communication, hopefully. Communication is the underpinning whole concept of this type of role. So that way we don't fall into the pitfalls where we think we're a good communicator, but maybe we're not. My wife's the master communicator, and I'm usually the person on the left in our conversations. So at the end of all this, you'll hopefully have a product, a clinician that can actually work together with a team, a multidisciplinary team in secondary care. And this is a photograph from Morecambe Bay Trust, and they actually put out a advertisement for physician associate in 2015, and that's an image of that ad that they put out on Twitter. It's on their Twitter feed. And they can work in general care. They can work in primary care as well. And this is a primary care practice in Manchester that they did a little video on.
Role is perfect.
And City Health Centre is a new practice, so we work in a different way. We're 8 to 8 practice. We're open every day of the week. We have a walk-in centre alongside the general practice. We have a young population, and our health needs are completely different. One of the problems we face is there's
Sorry about that video feed.
there's not a need for your traditional practice nurse where you have chronic disease, because we just don't have that. So what you need is somebody that can also do sexual health, somebody who can also see patients and help out with the workload. The PA role comes in ideally for that, because it's somebody that you can take on who has got a generic skill set that you can then train to be the person that you want.
I think I've been very lucky actually to be placed in GP first, and I've been able to build on my consultation in patients to seek medical attention.
That
Quick fix stuff. So what makes them different as far as how they fit into the multidisciplinary team is they're generally trained. They come in with a general set of skills that they learned in that first year and during their placements in the second year as well. Blow that up a little bit. And they can be modified, and they're trained in the medical model, and they can be modified or trained by their supervising physician. So the physicians are actually in direct responsibility for how that PA is used. You don't have to go through any kind of other organizations or any other kind of certification bodies to actually tell that physician assistant what his responsibilities should be or modify his responsibilities. And you can develop his training program based on what your service needs. And they answer directly to physicians. And if you're trained like I was, the multidisciplinary team is the decisions are made by the patient, and the doctor physician is in charge of the team. And also believe that doctors should be more involved with administration decision making as well in secondary and primary care. They're adaptable to fit, we've mentioned before, in any clinical situation. Their specific role can be determined by the service needs and what you believe, the physician believes they're capable of. So you can make that determination based on what you think that individual's strengths are and what their weaknesses are, and determine what kind of skills they can have. And they're a stable member of the ward's clinical staffing as well. That's one of the big things you hear from St. George's, is that they're a role that actually stays on the ward all the time and doesn't go to different wards and doesn't go around to different placements. I had one of my students come to me the other day and said when they were working in elderly care placement, they were there on a Monday, and the consultant had to go to a rota in Carlisle, and they had a new SHO and a new registrar that had just started, and they had just changed nursing staff over the weekend. So everybody on the staff was new, but he had been in that placement for 2 or 3 weeks and knew all the patients that were on the ward, so he was able to kind of give them some direction, not necessarily tell them how to treat, but he at least knew what the plans were for each of those patients and was able to kind of direct them and give them an idea of what was going on. So he was a stable member of the staff, even though he was a student. So at the end of the day, we're all working together as a team, and we can go back at night and hang out with our friends and go to relax somewhere.
I'm losing them.
It happens.
I don't know, sometimes I think a trace solution of deadly nightshade or a statistically negligible quantity of arsenic just isn't enough.
That's crazy talk, Simon. Okay, so you kill the odd patient with cancer or heart disease, or bronchitis, flu, chickenpox, or measles. But when someone comes in with a vague sense of unease, or a touch of the nerves, or even just more money than sense, then be left with a bottle of basically just water in one hand, and a huge invoice in the other.
I suppose you're right.
Now, another drink.
I need one.
Excuse me. 2 more homeopathic latkes, please.
Well, that's strong stuff.
Laugh if you want, but we actually have one of my students that actually studied homeopathy for a time. She wanted to get more, she wanted to start actually training in a more Western medical model. And then I realized, I think homeopathy was started by a Westerner anyway. An English fellow, I believe, started homeopathy. But am I right about that? I think it was?
No, German.
Huh?
German.
Yeah. So, as it stands, though, she actually got a 97% on her pharmacology exam just recently. She's one of our stronger students. So I had a lot of discussions about that with her, and she's kind of left the homeopathy by the wayside. She doesn't really believe in it so much anymore. She didn't really when she took it either. So that's the end of that presentation. So I'd like to kind of open the floor up to questions if you have any. Yeah.
Just an observation, really.
Yeah.
The example you quoted of your student being the only person in continuity on a ward, it says more about the health service than the physician assistant.
And that's
doesn't
the
it?
problem
It's just
with
shocking.
that place is that they have a really hard time. The consultants are going back and forth between West Cumberland Hospital and Carlisle all the time. The ACPs do a wonderful job in the EAU and the A&E. When I work on EAU when I'm in the hospital, West Cumberland Hospital, and to be honest, to be fair, we'll probably have about 6 consultants that go through that rota and rotate through it. So we'll have 3 or 4 different consultants throughout the week. They're seeing these patients in EAU, and they rotate around between the registrars and the SHOs that take responsibilities for other things. So there is a significant staffing problem there, and they're hoping that some of these mid-level practitioners can help fill those gaps and always be supervised by these clinical professionals, by physicians, to help distribute care safely.
When I don't know how much you know about when they qualify, but because I spend some time at foundation meetings,
Yeah.
I hear what the other hospitals are planning in the Northwest. When they qualify, do you expect that they'll get a job, say, in example, in GP or A&E or wherever, and that's where they stay? Or do you expect that they'll kind of get put on some sort of like rotation when they're newly qualified?
Most of the ones I've talked to so far have stayed very stable in the positions they go in. We have a few PAs that are working in the Cumbria area in GP practices, and they've been in those GP practices now for 2 or 3 years, and they're a stable part of that. I've gone to the FPA, the Faculty of Physician Associate meeting that they had this last year, and I met some PAs and clinical practitioners from Wales, and they had developed some really good models about how to give healthcare to their populations there, and those PAs have stayed in those practices for 3 or 4 years, 5 years.
Because I think some hospitals in the Northwest are planning on having like little rotations, like when they first start, and then I don't
And
know
that
how
could
long
be,
for
they
1 or
may
2
do that
years,
between
and then-
Carlisle and Carlisle and Whitehaven.
But between specialties, I mean, as well.
In between
around-
specialties.
yeah.
Oh, yeah.
And then
And that's one of the things that makes the model nice, is because they're generally trained, so they're very adaptable to fit into those situations. Oh, the other thing I want to mention is that when they have to requalify every 6 years, they have to retest on all those 1A conditions that they originally had to test on. So they had, even though they're doing trauma surgery or orthopedics, they still have to know how to treat balanitis or an ear infection without any kind of consultation. Yeah.
Thanks, Matthew. Can
Yeah.
I just ask what pay bands they're on when they qualify? When they finish, and what's the career?
I'm sorry, start that sentence
What
again.
pay band are they on? What is the,
What pay band are they on?
and what's the career prognosis?
What we've seen so far is that most of them start out, they say they're going to start out at band 6, band 7 areas, and it's in general, I'm actually seeing more like band 5, 6, kind of in that range there when they start out. And then when they get more qualified and get more specialized, they can go up to about an 8A, somewhere around there. And that's generally where, at this point, that's where they're staying. Yes?
What are the entry requirements?
The students that are currently in our program, they have to have 2-1 in whatever they have to have a degree in biomedical sciences or whatever certification they already have. They have to have 2-1 in that degree that they have. So,
Will it be broadened to arts graduates, as medicine has been for?
what's that saying?
Will it be broadened to arts graduates as well, like medicine has been for a while?
I don't know if they'll do that or not. At this point, it's basically based on science knowledge. Now, if you are qualified or if you have some other kind of degree and you've worked in the clinical environment for multiple years, not necessarily as a certified person in a certified kind of profession, they might consider you for that role if you have a lot of clinical experience. That might trump that. As long as you have a degree, then you still take that. But I think that's somewhere down the line. I don't think that at this point they're still taking just people that have a really good science background for their first initial degree, from my understanding. At least that's where our program's doing, and that's what Liverpool and Manchester are doing as well.
Excuse me, when you say science background, do you mean biomedical science?
Usually biomedical sciences, yeah.
They wouldn't take an engineer, say?
I think at this point they're not looking at those kind of things, yeah, not engineers, not anything in physical sciences. It would be biological sciences. Yeah. Any further questions? Great. Well, thanks for coming.